Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Sally Daganzo, internal medicine physician. Today's Kevin MD article is The Hidden Epidemic of Orthorexia Nervosa. Sally, welcome back to the show.
Thank you for having me. Excited to be here.
All right, so give us some context. Tell us what orthorexia nervosa is and why you decided to write this article on Kevin MD.
So, this article, I think orthorexia is a bit, maybe some people have heard of it, but basically it's trying to eat correctly all the time. Some people might call it clean eating or something like that, but it's when it becomes basically taking over somebody's life. It's not an official, ICD-10 code or DSM diagnosis, as far as I know, but it is something that I think people likely under recognize. So that's for context, is sort of this like healthy eating to an extreme where it becomes inflexible. And since I do a lot of eating disorders, that's my primary practice. And then I've also recently trained in functional medicine, which is maybe similar to lifestyle medicine. And so there's this convergence of those two that I sometimes see or maybe recognize more. And that's what prompted me to sort of put this out there for other people to maybe be on the lookout for.
All right, so what separates adherence to a diet to something more pathological, like you suggest here?
Yeah, I mean, I think, it can start, I liken it to somebody who might be like predisposed to something like OCD or obsessive compulsive disorder, and you may not know it. So it may be that they just, oh, I had a like maybe, somebody has a heart attack and then they decide they want to, stop eating meat or whatever it is. And then suddenly it just sort of takes over their entire life in terms of, afraid to go out with friends because they don't know what's on the menu and if they'll be able to eat anything. It may be they're eating something different than the rest of their family. Really, that it, like with any sort of psychological diagnosis where it's interfering with their sort of ability to do their day-to-day life, and they can become sad about it and it takes over kind of all of their thoughts. Maybe not all, but it can be hard to recognize, right? It's a fine line, I think.
Now, when a patient with this condition presents to you at a clinic, what are some typical presentations or stories that you see?
I mean, typically, so they may come, so there's the eating disorder patients. It's already we're looking at that. So that's maybe separate but overlapping, and that's like anorexia, bulimia nervosa, binge eating disorder, these other kind of DSM defined things. But you might see somebody with, I think a lot of us are familiar with small intestinal bacterial overgrowth or SIBO, which maybe I think is a little bit trending on the internet these days, or maybe not so much, but where people feel like bloating or they feel like uncomfortable in their stomach. And so they might have seen their regular doctor, or they may have seen a GI doctor who's like, oh, it's just, just take Pepsid or omeprazole. That doesn't really help. And also that has other problems. And then they're looking for more answers. And people often, I think we turn to food because it's everywhere. And so they're looking for, well, maybe if I get rid of gluten, because, at least out here in California, gluten is this like awful, evil thing, or, dairy, because a lot of people are intolerant to dairy. So those are the two biggest ones. And often we're recommending that, right? It's not, it sometimes does help. And so maybe they get rid of those things, or maybe they come in getting rid of those, wanting to get rid of them. And then suddenly, they're either losing weight or they start eliminating more and more things because they're a little bit better. And then, well, maybe if I do this other kind of also get rid of this adjacent thing like all grains,
Mhm.
because I heard carnivore was good from my, other person. And it kind of ends up being this obsession with like, what's the next thing to sort of now feel even better if they've gotten, maybe they did get a little improvement because I mean, a lot of people do feel less bloated when they cut out gluten. That's sort of probably true for everyone, just by the nature of how gluten is in our body. But this becomes sort of an addiction almost to the next kind of what do I get rid of next until they're limited. And then when you try to add them back as the other thing, there's a lot of fear around
Mm.
it. Like if I add it back, something bad will happen. They may not say that, but it's almost like this resistance to putting it back in, where where that's where I liken it to something more like OCD or something. It's like I just can't do it. And they may even recognize it's a problem and don't know how they got there. So that's what I see. I mean, I think maybe in the primary care setting or somewhere else, maybe it could be more subtle. But my point of writing this was when we recommend some of these lifestyle interventions, I think it comes from a place of, yes, these are the right things to do. They're going to help, but maybe screening for anxiety disorders or other sort of even family history and making sure you have a follow-up check-in or
Mm.
sort of these basics to make sure it doesn't go too far because I think we're just not used to thinking that way with this more of an obesity epidemic, which we cannot deny that either. I don't think that that's also an ongoing situation.
So one of the things I'm hearing is that sometimes well-meaning advice, it could be in a primary care office or family members giving well-meaning advice. If that patient is predisposed, you mentioned a history of anxiety, for instance, it could actually trigger this shadow side, like you said, of lifestyle medicine. It could trigger this orthorexia nervosa.
Right. Yeah. And actually, just yesterday, I was seeing of a young person with anorexia. So this is slightly different, but hers is a very orthorexic form. Like it looks like she's eating spa food all the time, and she's like, a teenager. And I mean, like, yoga retreat, weird, and not weird food, but just not what a teenager would be eating. I've got
Hmm.
three teenagers, and or even adults. And so, but it was interesting. Her parent shared with me that he has a memory of her going to a health class in middle school or elementary school. She has no recollection of it, but her coming home and like they had talked about like healthy eating and I don't know, food groups, whatever it is, something seemingly benign at school, trying to teach about, healthy eating, I guess, right? Which seems innocuous. And he acted like that was like a light switch where it was like, oh, I could do that. I could eat healthy. So there's also this like perfectionism that
Hmm.
can happen. And, in adults, we may take it for granted that that's not an issue, but something can trigger that. So even screening for, not necessarily screening, I guess, we don't have time to screen for every single thing, but I do think we take that nutrition advice for granted. I mean, sometimes it's simply in an after visit summary that we send to somebody, right? It may not even come out of our mouths as
Hmm.
like a conversation because we don't have time. And so that's where I think a little more thought and care could go a long way to protecting us from having another problem.
What are some of the
Yeah.
long-term consequences if this isn't diagnosed and treated appropriately?
I mean, definitely, I mean, it could turn into anorexia, right? But also just eliminating food groups, right? There's malnutrition. So, like with any sort of extreme diet, if you're eliminating, you know, whole food groups, you really you know, you don't function. Like you need your omega threes, you need your vitamin
Mhm.
A, you need, there are all these things that I think, we kind of learn about in medical school, and then
Yeah.
we just sort of assume the engine's going to work no matter what we give it. Spend a lot of time on that as well. But we actually need like a very complete diet to really thrive. And even I think, the other place we see it, or I see it, is things like perimenopause or as we're getting older, people like feel like more tired or more, we're taking care of, our parents or our, children. Like there's a lot going on in midlife. And so people thinking I could just clean up my diet.
Hmm.
And then the other thing we see is, I guess, lower calories, like just a lower intake overall, which actually gives us less energy and less nutrition, which we're not always talking about that either. So, yeah, I mean, like all the consequences you could get with anorexia or malnutrition, osteoporosis, dementia, just like, list goes on. And I mean, the most obvious one would be things just like anxiety and depression, because our
Hmm.
mood is really not well supported when we're not well nourished. People people want to like I think work the system like,
Yeah.
oh, well, maybe if I just take a multivitamin, can't that do it? But it's not. You need
Hmm.
the food.
So, in your story, you said that something as benign as a health class can sometimes trigger this. So, tell us how we could individualize nutrition and diet advice. So, for me as a primary care doctor, if I wanted to give nutrition advice in the exam room, what are some ways that I can individualize it to that patient? Maybe some questions I can ask before I give that advice that can that may uncover a predisposition to this. So what are some approaches for that?
I mean, I think just asking something like, have you ever, been afraid of gaining weight? Like, is a basic question. Or have you ever been like scared of food? Do you have a history of an eating disorder, right? If this is people in their 50s, like they may have had a history in their teen years and just thought it was gone. And I see that all the time where it just like resurfaces and people are just taken by surprise almost.
Mhm.
They didn't think it could happen. And I think that's a pretty, if you're going to go into a conversation about nutrition, I think it's a pretty obvious or natural question to say, hey, before we talk about this nutrition advice, I just want to double check. Do you have any history of being fearful of food or a history of an eating disorder or even family history of anything like OCD if you wanted to get more into that? But I think just asking for that and people are pretty honest and you
Mhm.
can, frame it in the way like any primary care doctor, just frame it in a way is like, so I can give you the most careful, personalized advice about this. I think it is really reasonable and we're probably not, I mean, I know I definitely wasn't doing that at all until I started kind of seeing
Mhm.
more and thinking about it. And we had this, I think there's just been this wave with the GLP-1 and, receptor agonist. There's just been a lot more
Yeah.
attention around nutrition and lifestyle medicine in the last couple of years, it seems like. So I think it's a good opportunity for us to rethink how we're delivering this, for doctors, very basic advice like, oh, well, just eat this
Mhm.
balanced diet, eat this new, don't eat so much garbage and do this and do that. And then suddenly people are like, garbage, what? Oh my gosh, and then it's off the rails.
Mhm.
So, because people take what we say, not everyone listens, a lot of people don't listen to what we say, they don't make changes, but then there's these people that really, take it
Yeah.
to a T.
Now, if someone were diagnosed with orthorexia, what are some treatment approaches that you've implemented in your own clinic?
I mean, the main thing, I mean, I always work with dietitians, which isn't, I don't know if that's accessible to all, not everybody is willing to see a dietitian, but I find a dietitian to be like one of the most valuable people as part of a treatment team. And so, like, well, a lot of places do have access to that. So dietitian, a great dietitian, even just one visit with them, but also exposure to, you know, looking at like what are they most afraid of, what's driving
Mhm.
that, and then like how can we just do a gentle exposure if you think that they are have eliminated a bunch of foods but they're not really having anorexia or something like that, talking about like what can you reintroduce, which is kind of is the treatment we would do for something like OCD too. It's just
Mhm.
this exposure therapy, kind of rip the band-aid off. And what's going to happen if you eat a piece of bread if you've been not eating gluten for a long time? And actually counseling them that the first time they reintroduce something, they might feel kind of bad. Like that's something to be expected. If you've eliminated a lot of foods and you add them back, your body may not be used to it. And that doesn't mean you're like allergic or intolerant, which I think is the other trap people can get in. They get rid of something and they add it back. And it's like, oh, I can't eat it because now I feel funny. Well, their microbiome probably changed, or I don't know what's happening on the molecular level, but our bodies adapt to what
Mhm.
we give it. So I think just if we have that sort of pre or anticipatory guidance about what to expect, if we do add things back, and then, working with them on not having things be black and white and being a gray area and flexibility. Yeah. So it's hard. I mean, it's hard. But I think naming it just helps people see like, oh, when it's not really a
Mhm.
clinical anorexia, it helps people see like, oh yeah, maybe I have taken this too far, and recognizing that even that your doctor is saying that you don't have to be so strict can also be a relief for some people. Like it doesn't have to be so you can't have any cholesterol if you've had heart, you cannot eat an egg ever again if you've had a heart attack, or maybe I don't know if that's a good example or not, but that's, I think, working with the gray area and helping these sort of perfectionist, rigid type
Mhm.
people, which some doctors are too, work in that gray
Sure.
area, which nobody really likes. Nobody likes gray areas.
Yeah, yeah. We're talking to Sally
So,
Daganzo, internal medicine physician. Today's Kevin MD article is The Hidden Epidemic of Orthorexia Nervosa. Sally, as always, will end with take home messages they want to leave with the Kevin MD audience.
I think the biggest one is what you mentioned earlier about if you're giving nutrition advice, just check in if they ever had a history of an eating disorder or being afraid of food. I think that's an easy one to implement. And I hope that some people will at least some of the time and see if that opens up any conversations with your patients. I think you could help a lot of people.
Sally, as always, thank you so much for sharing your perspective and insight. And thanks again for coming back on the show.